When it comes to prostate cancer, it's very important to have an accurate diagnosis so that we can organize proper treatment for the correct type of disease. Certainly PSA is the most widely used test to screen for prostate cancer. However, it does have its limitations. It certainly can find a lot of disease, but it often can be low-grade disease which does not need to be treated, which leads to overdiagnosis and overtreatment of prostate cancer. A biopsy would be used after an elevated PSA is identified to determine whether the patient in fact has prostate cancer. Certainly biopsies have come a long way. We can do them on an outpatient basis now very conveniently for the patient, but they still are an invasive test and there is a risk of infection with them. And so therefore, if we could come up with another way at some point in the future, that would be desirable.
There's a need for a marker, and that's what we try to do with our 3D telomere analysis.
So Dr. Mai's team has combined two state-of-the-art technologies together so that we will be able to get a 3D picture of the overall changes in genes, and this can be developed into a simple blood test that can be used to test prostate cancer patients.
The first stage of the project involved patients who are intermediate risk, 200 of them, and we were collecting blood samples from the patients, and then we were isolating circulating tumor cells from the blood of the patients and use those cells to perform three-dimensional imaging, 3D imaging, to understand the nuclear architecture of the cells. So it's like a liquid biopsy without doing a biopsy. So you take a blood sample and you can analyze the genome in 3 dimensions of that specific patient and of each individual cell of that patient.
This research could possibly change the way the world tests for prostate cancer.
You will be able to say for each patient at that point in time if the patient is with stable disease and doesn't have to worry, or if the patient is with a more aggressive form of disease, and then I don't think he needs to worry because then we can decide which treatments. But the most important thing is that we choose the right treatment for the right patient and don't treat patients who don't need treatment. Dr. Julius Arve is a PhD student in my lab. He is a trained medical doctor. He has done the bench work on this project. He has proven that this works.
This cell is a dying cell captured in the bloodstream. It shows the severity of the stage of a high-risk patient compared to the patient, which when you put the nuclear architecture, you see that it's still smooth and it's still a viable cell, and this is from an intermediate risk patient. It feels so nice to help fellow humans and also I might not know who I'm saving, it might be myself in future. So it's a great thing and we are happy that we are contributing and we are making good use of the funding we are having.
The support from Manitoba Right for Dead was instrumental to get this work off the ground. The 3-year study that we have done, we are writing up the papers now as we speak. There will be 3 papers coming out of that. And then the sequencing work, 3 patients is not enough. So we will focus on a group of 40 patients that we have already identified. Next generation sequencing is not very cheap. It costs easily $10,000 to get the sequence of 10 circulating tumor cells. I mean, that sequencing, if we get the funding, should be done in a year.
Bringing up research to clinical trials takes a lot of time and patience and effort, and certainly the ongoing efforts for fundraising are greatly appreciated.
Without them, we wouldn't have gone this far, and with them, we will go a lot far and even be able to validate our methods and techniques. Thank you, Right, for that, for your support.
I think we can be a strong team that involves the patients, the clinicians, and hopefully funding from Right for That.